Thank you so much, Rio. I I'm really glad to be here. It's a real honor and to take to have time to kind of contribute to NEMC a little bit, but also to our profession, hopefully, and all of our folks that have logged on. I quite excited to really kind of talk about this uh, topic. It started out, I'll give you a little history of it. Started out when I read a couple of research studies, and it was kind of actually, to tell you the truth, I found it quite disturbing. And I thought, you know what? There's something we're not talking about, and something that we need to include in our programs. And what a way to both improve our care but also to kind of foster the next generation of leaders. So that's where we're going to head to today, and I look forward to sharing with you what I've discovered. My first issue here is to wish you happy EMS week. It's the 50th EMS week, and some of you have been here for all of them. I have not. But I have been here for 40 of them, so that's kind of exciting. I just hit my 40th anniversary, so I'm honored to be here. And MZ's played a big role in my career. I would not have had the career I've had without NEMSI for sure. I was a brand new program director. I went there at the advice of a friend, and I met so many wonderful people that shared so many wonderful things with me. And I've always held on to the idea that that's the way to do it. And so throughout my career, I've tried to share with others as well. And I'm just really grateful for everybody at the organization and all of you family members. I call you because every time I go to a symposium, I feel like it's a family reunion, which is really a good time. So I'm hoping to join the one this summer in Pittsburgh. I should know soon. Anyway, it's all good, and I just want to thank you for all you do. It's a big job and a lot of work, and what we do is really, really important. Hey, I am in Minnesota, and the other night we did have some northern lights, and I wanted to share a quick picture of that with you. I found myself out on a gravel road with strangers all looking at things, and there was a interesting unity that developed among us because we were all there for the same reason. Nobody knew each other, but it was a dark place. There were a couple power lines there, but man, was it a show. It's kind of a good reminder that perhaps it's not all about us, right? All right. A few objectives today. Want to identify the role of research in teaching difficult subjects. And by difficult, I mean those that we don't talk about, not like, the oxyhemoglobin dissociation curve, but how do we treat people when we actually perform our duties, right? And we want to recognize the high acuities often found in homeless patients today. So it's a very complex population and they have very high acuities, as you will see. We need to examine the cross-cultural pain management approach as well and see who gets pain med and who doesn't, right? And then we want to contrast our biased patient care with our code of ethics. So, yeah, not the easiest subjects to tackle on Thursday before a holiday weekend, but hey, thank you for coming and being willing to do it, okay? All right. Here's some fundamental principles that I thought of when I prepared this for you. True education occurs when we teach non-biased reality, right? So we just put it out there for what it is. We're honest, we're authentic, we give folks the truth, and then we can recognize what to do with it, right? So professions advance when they're willing to look at themselves objectively, uh, recognize their faults, and also make necessary corrections. You've probably met folks who, there's nothing wrong with them. It's everybody else's issue, right? Well, the same thing can happen with professions and the cultures in professions. Folks can think, we got it all together, nothing wrong with us. We're great. It's all their problem. And in reality, that's just not accurate, right? Our students are the next generation of leaders in our profession. When you think about it, people in your classes, people in my classes, they're going to be running things. Some of them are. And my theory is we should treat them as if that's who they're going to be, because in reality, some of them are. In doing that, I really do believe we have an imperative to share with them what's real, and that leads me to our discussion today. So, we also know, though, that professional cultures change when leaders model them daily. So, if we give students this information while they're with us, while there's still a blank slate or a tabula rasa, right? We can tell them what it is up front, right? They don't have to discover it for themselves. And I believe that that can truly lead to some lasting change. We do have a North Star to follow, um, and that is our code of ethics. Okay. And those ethics should guide our practice, right? And they should guide the practice of anyone who graduates from your program, right? So in that code today, I want to focus on a couple things. The To conserve life, alleviate suffering, promote health, do no harm, and encourage the quality and equal availability of emergency medical care. So um, that's an obligation that we have, right? That's what we sign up for when we become EMS providers. And as educators, we need to make our students aware of that and hold them to that. I have a copy of this entire document in our program manual, and I think it's a good idea. And they sign that program manual, and it says, I will follow this and I will do these things, right? So it's very helpful. There's one other piece: to provide services based on human need with compassion and respect for human dignity, unrestricted by consideration of nationality, race, creed, color, or status, and to not judge the merits of the patient's request for service, nor allow the patient's socioeconomic status to influence our demeanor or the care we provide. I mean, it's a hard job, and we deal with people that are in bad places. Their life is not good at that point they meet us sometimes, and it's a challenge. And we should share that with our students to let them know that. But at no time are they allowed to uh, not do these things, because again, that's what we've signed up for. When you think about it, at least for me, as I was putting this together, we really, if you just take those two paragraphs of the Code of Ethics, it kind of struck me that we're called to function in the realms of what many theorists describe as the higher levels of human development, right? I mean, wow, we already thought we had a big job, but now we're having to operate at a level of really without much higher to go, right? So let's take a look. We just a few theorists. I was thinking about Kohlberg's, moral reasoning, and the Piaget's top level of formal operational. Maslow has his self-actualization, and then top of the triangle had a little transcendence area, right, where that was kind of the ultimate. Mesereau, great guy. If you haven't read any of Mesereau's work on adult learning, transformative learning. That's where people not only learn, but it changes them and who they are, and then they go out and try to make the world better, having that knowledge, right? And then Malcolm Knowles, of course, the father of andragogy, his problem-centered area where folks get to a spot where they're able to really consider some things and what needs fixing, and what's good, and go from there. So if you're into adult learning theory, uh, those guys would say that we are up at the top, right? Just because of the assignment that we have to follow our code. And when we do that, we're operating pretty high levels. I wanted to give you two key philosophical concepts here too today. One is that reality determines value, right? Reality determines value. So um, when things get real, uh, what we value comes out. Our that's when we reveal who we are, right? And this is a philosophy professor at Harvard, Christine Korsgaard. So reality determines value, and the other is what you value is what you will be. So going forward, if this is what you value, that's what you're going to be, right? Or at least most of the time. I mean, we're human; we make mistakes, but by and large, we're a little existential here. But hey, what you value is what you will be, and this is from a fellow named Clarence Jordan, who is a fascinating man. He's passed away. But he was one of the founding fathers of Habitat for Humanity. So he's got a really interesting story if you want to look him up. But those are the two things, the kind of the foundational concepts I wanted you to kind of gather from this as we go forward. So, but reality determines value, and what you value is what you will be. The two keys, right? So, what about reality? What about it? You've all heard this. That's not how it's done in the field, right? And the first time a student comes back and says that, I go, it's never going to end. It's just going to keep going. I mean, this subject, this topic, this statement will never end, right? So I've given up on trying to change that. But on the other hand, it's a perfect time for a teaching moment, right? Because my response is perhaps how it's done in the field is wrong, right? So yeah, I mean, there is always that possibility. I mean, just because it's done in the field doesn't make it right. So, well, you learn the book, but this is how it's done in the field. You know, well, you've all heard that stuff. Um, I think there's room for both, right? We don't have to be dualistic thinkers and have it one or the other, either or, and live our lives in black and white and this weirdness of off or on, right? We can entertain more than one concept at a time and not have it freak us out if we're operating at that higher level, is what we the theorists would say we are. So when we think about those things, um, you've all had students probably who came in with a lot of experience, right? And they had a lot of stuff to unlearn. And then you in the same class had somebody that had no experience. They're right out of EMT. They're in your paramedic class. Um, and how much easier it was to mold the one who didn't have any. Right? Now, experience is not bad, but good experience is what you want, right? You want to be around good people that model good behaviors and have good preceptors and FTOs and all these folks. So, and it sometimes doesn't happen. So sometimes when we recognize this incongruity, we have to act, right? We have to act. And I often tell my students that sometimes you'll see how not to do things. You'll learn how not to do it based on whomever you're with. Right? Some preceptor's behavior is not good. They'll learn how not to do it. But my goal for them is to recognize that and to know the difference and expect them to do it the right way. And even though that's how they do it in the field, it doesn't make it right. So learning and teaching folks how not to do things is as important as how we teach them to do things, right? And calling it out. And I hope all of you do preceptor evals so that the students can evaluate their preceptors and tell you if somebody's, really not a person you want a student with. And sometimes they're just having life issues. We all know that, folks are looking at bankruptcy or they're going through a divorce or they have a substance abuse issue or whatever it is. And it's not obviously a good time for them to have students. So you kind of think about those terms and those ideas, and you want to make it right. Okay. So having a willingness in your classroom to include the challenges our profession faces truly can plant the seeds for lasting change in our profession. And, We're looking at it from the time they're there, right? You say, well, they're not even paramedics yet. That's okay. We can plant seeds long before that, and they can start to grow. And then when they start to progress through their career, um, they're going to have a good foundation. They'll have the roots that are solid, right? And so that'll be good. That'll be very, very good. All right. As an example, now I got to tell you about two of my dear friends, Mike Miller and Bill Leggio. And both of them were at Creighton University for some time. And now they've gone on to big things. Mike's at Coe and Bill's at Mayo. And wow, amazing people if you get a chance to meet them. And I believe they were going to try to join us here today on the call. And so not only do I have a study for you, but I have at least one, possibly two folks who did the study, right? And this study bothered me greatly. I have to admit this. Yeah, anyway, we're going to get there. So, according to the U.S. Department of Housing and HUD, 22 count, right? Data is always about a year or two behind because it takes time to really make sure it's correct, right? But look at that, about a 500,000 people experience homeless in America, right? And here's the deal: you've got folks all over the country. In the dark blue areas, you can see you have a higher population of homeless folk. And these are the total numbers you're looking at under their state abbreviation. But if you look at the color, you'll see that 50 plus out of 10,000 people are homeless in these states. And then if you go to the very light blue, powder blue, it's less than 10 in 10,000. But that's a little deceptive because look at Michigan, 8,206 people. That's still a lot of people, right? And it's folks, it's relative, it's compared to their population, obviously. But if you think about it, those are 8,206 family members, and they're people who are in need, big time, and people we're going to take care of just by nature of the fact that they're homeless. It lends itself to meeting EMS at some point, usually, right? For whatever reason, as we'll see in a moment. Any rate, that is a big challenge, and these are numbers that are there. So Mike and Bill teamed up, and they did a study a bit ago, and this was all about homeless patients and EMS. And it was an example of the need for us as EMS educators to include effective education in EMS. But what they found, and they had their students actually conduct some of the interviews, which was a very novel idea uh, because they were exposing their students to research and they were getting them involved in these kind of things to think about stuff like this bigger than maybe just the ACLS algorithm. Uh, but what are you going to do about this, right? When you get out, and how are you going to handle this? So, some hard truths of the matter that and they cited a lot of studies in this. This was in the NEMSI educator update, by the way, in the domain, so you can look that up. But students have shown homeless patients are 3 times more likely to visit EDs more than once a year and are shown to be associated with repeated ED use. So almost half state ED as their only source of healthcare. So that's a reality. And many call EMS to get there, right? So folks, students need to be aware of that. And nearly a third felt like they were treated rudely by the ED staff. Oh boy. And this is where it becomes problematic. And nearly half feel their problem was not taken seriously. And about 40% sought care at a later date for the same problem, which perpetuates the madness, right? So the staff continues to feel, perhaps some of them, that, oh, this is never going to end. Well, their behavior might be playing a role in this, right? So when you look at health challenges in the homeless, you've got folks that older in age, perhaps, previous hospital admissions and ED visits, inadequate mental health care, poor health status to begin with, uh, some of whom have HIV infection, hepatitis. You have folks that struggle with addiction. Nearly half of homeless folks considered themselves as having drug or alcohol problem in the past year. Um, Look at this environmental exposure, maybe not one you kind of think about, but if folks are sleeping out in the cold, they may have chronic hypothermia, right? If it's really hot there, they may be hyperthermic. They may be, having issues constantly with staying hydrated. But folks don't have the best diets, obviously, poor dental hygiene, uh, STDs, assault, and you get to female homeless folks, and they're more likely to engage in prostitution and what's called survival sex in exchange for food, drugs, or shelter. Okay, so this is really involved. Pregnancy rate for homeless females is double that of the general population as well. So lots and lots of stuff to do. And if a student's on a clinical and they get a call for a homeless patient and the preceptor's like, oh, a homeless person, why don't they go get a job? I mean, you've heard all this stuff. Uh, wow. Wow. That's like, a guy coming in with an MI and them complaining because why do they eat so much red meat? I mean, let's address the problem, right? Rather than uh, complain. So that is our goal to teach our students. Homeless patients are at increased risk for heart attack, stroke, respiratory illness, obviously all kinds of stuff, TB, but pneumonia is very common. GI illnesses, including those from substance abuse, like esophageal varices, head injury, right? If people are assaulted, but also if they're older or if they've shrunk their brain from too much alcohol, they're going to be high risk for subdural. I mean, we know all these things. And then assaults too are all there as part of that. So it's a tough way to live, and folks have a lot of medical conditions and very high acuities when our people arrive there, and they need a really strong person to do a differential and try to figure stuff out and know the resources in the community in which to refer them to as it goes. So here's a part that bothered me greatly. Homeless patients with one or more conditions of addiction, mental illness, chronic pain felt judged and stigmatized, with clinicians assuming they're seeking out prescriptions for narcotics. So they were reduced to that horrible name of drug seeker that is really, that's the first place you go. I mean, and no assessment, there's no exam done. It's just you can tell that from the ambulance or from the ED bed. I mean, really. So these are just things that are not acceptable, and we got to call them out when we see them because these are our patients. These are folks that this is who we signed up for, to take care of people. So there's a problem and there's a paradox. And this, I think, you'll find interesting. Hopefully, or in homeless patients being treated brutally, feeling not heard, or consequently seeking care again for the same problem is an issue, as we saw. And that, of course, developed a mistrust that most likely has roots in how EMS treats and interacts with homeless patients. So um, if our patients don't trust us because when we show up, we don't treat them like we would maybe the president of the bank or whatever, that becomes problematic. And you know that people are going to trust you with their stuff and tell you their personal info and their medical conditions more likely if they trust you and if you're being kind to them, right? Healthcare providers often think if they treat homeless patients well, it'll encourage them to call more often, right? Yeah, well, we can't treat them too well. They'll be here all the time. That's kind of the theory, right? But look at this. Look at this. Research appears to correlate a demonstrated decrease in repeat visits from increases in homeless patient satisfaction scores after receiving compassionate care. Well, it's upside down from what maybe you thought, right? You're not perpetuating the problem. You're fixing it when you're kind and nice and compassionate and providing good care, right? So good stuff to know and really good stuff to teach, right? So homeless patients are some of the most complicated high acuity folks that we're going to see. And there's a critical need in the formative education of EMS providers and others folks too. I mean, nurses and take your pick, physicians, to learn the many challenges, conditions, and treatments for homeless folks. So it's a unique population that it's not covered too much in depth. And you say, well, how much more do I have to teach, right? I've got all these national standards and all this stuff, and I don't have time now to cover it all. Um, all I'm saying is build it into the fabric, and you can link it as you go through the entire program and talk about things. It doesn't have to be yet another module to add. Um, Awareness, though, of personal and collective bias among healthcare providers toward the homeless is a first step. You've got to do it. And every single one of us as human beings have personal and collective bias. I mean, it's who we are, right? So we got to get over that. And usually when we have bias toward people or a group, it's because we don't know anybody from that group. We've never known them. We don't understand that they're humans, that they have, have a life, and they were little once and they had birthdays and they had, things and celebrated Christmas just like we did, hopefully. But we don't do that. We don't humanize folks when we reduce them to a name like homeless, right? Or a drug seeker or no. The hard work comes when you try to understand people and get past those things, right? So why would a healthcare provider not treat a homeless person well? Huh, good question. My thought is um, they're enculturated maybe in a subculture of the here you go. I'm brand new medic. I go get a job at a place and I want to fit in. I want to be liked. I want to be there, right? I want to work. Maybe I have to act like others do in order to fit in. I don't know. Maybe there's just maybe people are burned out and just fried from dealing with folks for whatever reasons, and or they've been assaulted or they've been threatened, or there's so many reasons for this. However, we can't lose sight of the goal, right? Can't lose sight of what we signed up for. So what can you do? What can you do in your teaching to challenge this thing? I think discussing bias is a wonderful tool to begin with, and um, we live in weird times. I mean, as educators and people who hope to have students who are educated, you got to learn about all this stuff, right? You want to know about stuff. You got to learn it so you can understand it, and then you go from there. And um, discussing bias is putting it out there, and again, being honest, being authentic, saying, yeah, you know, um, let's check that so it doesn't get in the way and we don't miss things, right? We don't miss real problems these folks are having because they are very high risk for all these other things, right? We do that with pediatrics. We do that with, all these things. We say, don't, you know, these little ones are, they're going into shock and we're not recognizing it. And we wait till the blood pressure falls and they're in real trouble, right? So we talk about these things in other contexts. So why don't we do this here, right? How about scenarios? Can we run scenarios with folks that are, you know, get some standardized patients or get folks that understand that world to come in and craft the scenario around that so you build an affective component into that when you're teaching and when you can try to determine what is going to happen in that scenario and how did you feel, and be real about it, maybe get an old clothes, old dirt, something that stinks, people that have been, you can moulage people, and do they feel any different than they would a other patient when they took care of them, right? How about our test questions? Well, you know, I've seen some questions that were like not okay, right? Um, you're responding to the projects for a known crack addict who has this. I mean, you're just totally putting bias into stuff to perpetuate it. And we can't do that, right? How about this? Um, you respond to urban housing for Mr. Robinson, who is complaining of this, right? He does have a history of substance abuse, but it doesn't have to be this dramatic, crazy stuff that people grab onto, right? Case studies. Case studies are a fantastic way to go and very, very powerful to pick some case studies from your career. I do that every third semester. I bring out stuff that taught me the most, and I create it, and I have them have to think and really kind of do differentials and figure out stuff and tell me why, and it's really a very powerful learning tool, especially in the third semester break before they graduate because they have enough knowledge to really do good differentials. But you can do limited case studies all the way through. I mean, that's a great idea as well. And then how about research? Can you be like Bill and Mike and involve them in an actual research study? I mean, yeah, you could, but if you don't have that luxury, maybe you can assign um, some topics to your students and have them do some, 10-minute presentations. Get them thinking, get them into the literature and see what's going on out there, right? A very, very good idea. And, this whole concept of participating in research is truly one that is, magnificent because it shows us where we're doing well and where we're not. So, all right, going to shift gears. I want to leave a little bit of time for discussion if you have it too. But the other one that got me was the discussion on pain. And how do we treat pain and what do we do? And who are we treating and why? This is really disturbing. False beliefs about biological differences between blacks and whites continue to shape the way we perceive and treat black patients. Man, they're associated with racial disparities in assessment and treatment recommendations. And that's not okay, right? Look at this. From way back, people think some people think and believe and teach that Black people feel less pain than do white people and with inadequate treatment recommendations for their pain, right? And when they are given pain med, as we'll see, it's less than what our other folks are getting. So, not okay. And you say, well, that couldn't happen. Well, Uh, it does. And here it is. It's not just EMS, but it's emergency department as well. So racial ethnic disparities in management of acute pain, a meta-analysis, which means it's an analysis of many studies that have shown this. And so up to 50% of white med students, medical students, people that are going to be physicians, believe myths like black people have thicker skin and less sensitive nerve endings than white people. Um, they didn't just come up with this, they learned it somewhere, right? So that net that we're looking at is much bigger and wider than we thought. I mean, it's likely in their AMP classes or their, who knows what it is perpetuated. But when a doctor's saying this, you believe them when you're a student, right? Most of the time, you don't question everything, or else it'd be hard to get through school. But this is this is really problematic. And look at this: Black patients 40% less likely, and Hispanic patients 25% less likely to get pain medicine than white patients. That's a meta-analysis, right? This is not one-off study, an outlier. Um, what is up, right? Racial ethnic disparities. This is the big study, the Oregon EMS study that a lot of people has kind of started this whole thought, and they looked at 125,000 calls. I mean, it was a big number, and they boiled it down to who they could include and exclude. But look what they found: racial ethnic treatment disparities in EMS remain relatively unexamined, right? Unexamined, like nobody's even looking at it, right? And what they found was disturbing when they did it. So, um, you know, disadvantages in EMS treatment in Oregon. But honestly, um, I think this happens, across the board. And I'm not saying everybody, but it some, right? Hispanic Asian patients requested EMS in Oregon for traumatic injuries were less likely to have their pain assessed, even assessed, not okay. And all racial ethnicity patients were less likely to be treated with pain meds when compared to white patients. Wow. Disturbing? I hope it disturbs you. It disturbed me greatly. Not okay, right? So before we ask you what other topics need addressing, I think we got to talk about this whole concept of how do we teach pain? You know, do we treat, well, we should obviously start with positioning and an ice pack and see where we go. But if it's excruciating, we need to give people medicine. They're having a kidney stone or they're in an acute sickle cell crisis. Wow, really important. Um, why? I don't know why that, but there's room for a lot of studies. And that's my charge today to you, is to think about that. And if there's any graduate students among us and you're looking for a topic, in your master's degree or your PhD or EDD, there is tremendous amount of material here. It's really a gold mine of subject matter. And in talking with Bill and with Mike and preparing this talk, um, they both, thought perhaps a large quantitative study of, survey of folks across the country could really get to, by using their work, formulating your research questions, your study questions, survey questions from that, uh, could really take us quite a bit further. So that was one of their recommendations. And then you don't have to think up some topic on your own. You go to that study and you look under future recommendations for research. Hey, not bad. Um, that would be a marvelous thing, both in homeless population care and pain medicine. And are folks looking at it? And if they are, what they find? And how are teachers going to integrate this into their classrooms to eradicate this craziness, right? Let's call it out for what it is and treat it, and get on with things and keep looking at what's next, right? Remember, we're operating at the higher level. So this is something, guys, I show every year. And by the way, I include those two studies every single year. Those are assignments, the Oregon study and the homeless study, for my students to read and then comment on and discuss in class, because it just shines a light on stuff and it's a great way to do it. And it's not just me, their dad, talking to them again, telling them this stuff. So that's really nice. Um, this, though, is something I show every year as well. It's a powerful, powerful episode of the TV show ER. And this one starred Ray Liotta, and Ray passed away about a year ago. But um, this is a show that shows him come into the ED waiting room. He's obviously homeless. He obviously is really a mess, and how he's treated, and also how he's not treated. But wow, you talk about an effective, powerful moment. This is it. You show that, and every year I watch it, and every year I get all like, oh man. Um, when you do, you'll see it. You can get it on Amazon Prime. I think it's $3 or something. So I just bought it and just show it every year. But it is a powerful episode, about 40, 45 minutes, maybe most. And it's a good tool. And it kind of brings all this whole concept in together of everything we're talking about today, right? So I'd recommend that one. But today, the first step in making change, you got to recognize and understand the problem. I mean, it's just so critical. If we don't name it, we can't do anything about it, right? And treating emergency patients is no exception. There's no exception. In our practice, if we're going to be who we want to be, and we want to be the professionals that we want to have respect, people respect us. I hear it a lot. We don't get respected. We need to earn it. We need to do the good things, right? And then, hey, we can make a difference, right? We need to be willing, though, first to look at ourselves objectively in how we treat all patients before we can give our patients the very best care. And this is a big deal. All patients, right? Not just some, but everybody. Everybody deserves the same level of care, and that is excellent care, right? So be courageous, teach the uncomfortable, teach the truth in the classroom, show where we can do better. And that's exactly how I frame it. I say, we need to do better, and you guys need to do better. You're the future. You need to set the standard. Don't put up with this stuff. Do the right thing. And look at research as you formulate these things in your classes, and be willing to share it and encourage students to do that in their career too, because we never got anywhere without it. They laugh at me because I'm old, and we used to put 10-pound sandbags on failed chests and to stabilize them, and they just shake their head, and I shake my head too. I can't believe we did that. But through research, we learned that that wasn't the best thing to do. So racial and ethnic disparities in pain are not intentional in most cases. And this is important too. It's not that people set out to withhold pain meds from certain groups, but inequities are a product of a lot of complex influences, including implicit bias. And that is something people don't even know they have, right? So challenging folks while they're in school to wrestle with that. Wow, you think of the great care providers you're going to create. You're going to have them graduate and know they're making a difference, right? Good stuff. But we got to acknowledge and address it. So, in order to properly treat people, these are areas that EMS can lead the way in all of medicine. Truly. I mean, you look at some of those physician studies, look at some of the nursing studies. EMS can do it differently. This is something we can do, and we can make a difference. And I think that's a great thing in this field that all of us love. And it's the right thing to do, but our ethics also require it, as does the public trust, right? Yeah, all good. Here it is one more time: to conserve life, alleviate suffering, promote health, do no harm, and encourage the quality and equal availability of emergency medical care. To provide services based on human need with compassion and respect for human dignity, unrestricted by consideration of nationality, race, creed, color, status, to not judge the merits of the patient's request for service, nor allow the patient's socioeconomic status to influence our demeanor or the care we provide. There it is. It's not rocket science. Much harder to do than understand. But hey, we can do it, right? We're EMS folks. Yeah. I'll leave you with one of my favorites, Maya Angelou: do the best you can until you know better. Then when you know better, do better. And that kind of sums it up. That's true for all of us, every one of us, right? Um, we do things sometimes that we don't even know are goofy or wrong. And later we can learn it, and then we can make a change and do better and be better today than we were yesterday. And the same goes for tomorrow compared to today. I got a ton of references, guys. These slides will all be available, but there's a lot of stuff there and good stuff that you can use to sign your research studies and your 10-minute presentations to your class, right? Um, but it was fun to do this. It was fun to get the geek on and do some research and get it ready for you. And I hope it's been a valuable time. I know we're real close to wrapping it up, but we got about 10 minutes. Any thoughts or questions that you might have while you're thinking of them? Check it out. This is laying on the hood of the car, straight up the top of the sky, and this dome, these wild white shapes were going around at night, and it was just magnificent with the solar storm. So, all right. And Rio, I think I turn it back to you to read any questions. Oh, good.
Yes,
Yeah.
so let's
Okay.
see here. It doesn't look like we have any questions, but we do have some comments.
Okay.
So Carrie mentioned earlier that the bias and stigmatizing language that we do to our patients is dehumanizing, which perpetuates inequities.
Yeah. Yeah. Very true, Carrie. It's and we don't know we're doing it half the time because we learned it from those who went before us, right? So I think that is so true. We have to recognize that, oh, maybe I shouldn't say that. Maybe I shouldn't call people by their condition, the chest pain in room 3, that is a person there. And I don't think it's hard to use their name, right? Anyway,
Mike Miller, thank you for pointing this out. NEMSI members may access the full publication, Homeless Shelter Users and Their Experiences as EMS Patients, a qualitative study on the NAEMSP website and the Pre-Hospital Emergency Care Journal.
thank you, Mike. Thanks for coming too today. Big,
James, oh, I'm so sorry.
no, I just say a big shout out to Mike.
Absolutely. James says, thank you for covering the outlier populations.
Man, my pleasure. What would it be like to be in their shoes, right? I mean, that's what we have to ask ourselves. So, yeah.
We have lots and lots of thank yous. Joseph said this was fantastic, humbling and grounding, perfect for EMS week. Thank you.
Oh man, thank you. Thank you for that.
Morgan says, providing an instructor update to a number of educators across the state. I asked them to take one of the Harvard implicit bias tests. I was shocked at the
Yeah,
number of instructors who refused to do it.
I know. We live in weird times. Everything's political, Oh, I'm not doing it. Like, seriously, get over that. We're taking care of people's lives. And if we can't be self-reflective and admit that maybe we have challenges in areas like every human does, wow, that's all I can say. I mean, come on, man. We're better than that.
Absolutely. And it looks like that is the end of our comments here.
Oh, thank you all. What a treat to be with you and especially on EMS week. What an honor. I'm just really humbled by that, guys. Thank you for coming.
All right. And thank you so much, Dr. Kokx, for being here with us today. It's an honor to have you here with us. Perfect, like you said, perfect webinar for EMS week. So everyone, I did put the link in the chat to access the CEU, and I will be sure to include all of the information in tomorrow's follow-up email, as well as the recording of this webinar and the slides. So on
Awesome.
that note, I hope everybody has a fantastic rest of your day and rest of your week, and we will see you all next time. Thank you.
Thanks, everybody. Take care.
Bye.